Okay, hello and welcome to my channel. In this video, we are going to talk about the extradural hematoma. First, we'll give a short intro, then we will talk about the layers of the scalp, and after that, we will talk about the types of head trauma. Then we'll talk about the hematoma itself, the presentation, evaluation, and CT. We'll talk a little bit about the management, and then we have a short case to discuss in the end of this video. So, first of all, if we see here in this axial CT scan of the head, okay, you can see the classic shape of the hematoma itself, which is a biconvex or a lens shape, okay, that is pushing the brain to the other side. So you can see here what's called the midline shift, because the midline, the mid part of the brain, is being pushed to the other side by the mass effect, by the hematoma itself. And there is the classic view of the extradural hematoma. So first we'll talk about the layers of the scalp, okay? Here we have the skin in the yellow color. Then the white area would be the subcutaneous tissue. Then we'll have the gallia aponeurotica, which is the aponeurosis, but in the scalp it is called gallia. And then we have the loose connective tissue area, which is the connective tissue under the gallia. And then we will have the bone itself, which is in the blue color here, surrounded by the two layers of the periosteum or the pericranium, which are surrounding the cancellous part of the bone, okay? And then beneath that we will have the dura mater. So the hematoma or the bleeding that we are going to talk about is going to be situated here in this area, beneath the bone and above the dura or extradural, as the name says. So in the surgery to the extradural hematoma, after you're removing the bone, you will face the bleeding. It is the first thing that you will face. It is above the dura, okay? To make it easy to memorize, some people say you can use the synonym scalp. So the S is for the skin, the C is for the connective tissue, A is for aponeurosis or the gallia, and the L is for the loose connective tissue part, and then the P is for the periosteum or the bone itself, okay? So scalp. And here is a clearer image that shows the skin, and here are some hair follicles. Then the yellow one is the subcutaneous tissue. Then you have the gallia. Just forget about this label. Here is the gallia. And then we have the subaponeurotic or the loose connective tissue, as we said. And here you can see the bone and the pericranial layers. Here you can see the cancellous part of the bone. And here is a bony suture of the skull. And here is the dura mater, the fibrous layer of the meninges of the scalp. This green part, I believe, is a dural sinus, which contains blood. Okay, so the layers of the scalp. After that, we are going to talk about the types of head trauma. My resource is the Greenberg neurosurgery book. Okay, so we have four types or four classifications of head trauma. First one is minimal, mild, moderate, and severe. So in the minimal head trauma, the Glasgow Coma scale of the patient will be 15. The patient will be fully conscious. There is no loss of consciousness. The patient has not lost his consciousness at the incident site, at the, let's say, the motor car accident site. There is no amnesia. So the patient can remember all the things that happened during the incident. Then we have the mild one. The GCS of the patient may be 14. So when you are talking to the patient in the ER, he may be confused. Or the GCS may be 15, but the patient had loss of consciousness, which is less than 5 minutes, or altered memory. So the patient cannot or may not remember all the things that happened during the incident. Then we have the moderate head injury. The Glasgow Coma scale of the patient would be from 9 to 13. So he is not requiring intubation yet, but he may require, but he is not requiring it. Or he had loss of consciousness for more than 5 minutes, or he had a focal neurological deficit. So the patient may have a weakness, the patient may have a pupillary problem in the pupils of his eyes. So that's the moderate one. Then the severe one is the easiest one. GCS is below 8, okay, and the patient requires critical care immediately and requires intubation as well. So these are the types of head trauma: minimal, mild, moderate, and severe. The GCS is the main factor of it, but we will talk about the conscious level and the amnesia or the memory of the patient, okay? So let's jump to the extradural hematoma itself. Let's talk about the etiology. As I said, my source is the Greenberg neurosurgical book. So 1% of all head trauma admissions would be extradural hematoma. It is more common in males than females by the ratio of 4 to 1, because most young adults will work in the construction areas or will work much dangerous jobs, so they are more prone to injury. They say that the children or the infants below 2 years and the old men or the oldest people after 60 years of age, it's rare because the dura will become more adherent to the skull. And you can see that if you worked in a neurosurgery department before, you can see that the dura itself needs more time to be dissected from the skull in an old patient. So yes, that makes sense. The extradural hematoma itself is an arterial in origin. So most of the times it will be arterial, like 85% of the cases it will be the middle meningeal artery. And the middle meningeal artery itself is the most important artery in this hematoma. It's a branch of the maxillary artery, and the maxillary artery is a branch of the external carotid artery. So the middle meningeal artery is the most important one, as it enters the skull through the temporal bone in 85% of cases. Okay, it can also occur in the frontal or occipital areas. It can also be venous in origin, but the most important one is the middle meningeal artery. Okay, so let's talk about the middle meningeal artery for a bit. Okay, so it enters the skull through the foramen spinosum to enter the temporal area. It then branches to two parts, but this is not important. But if any injury or any blow to the skull happens here, there is injury to the middle meningeal artery that will cause an extradural hematoma. So as you can see here in this picture, this part is called the therion. The therion is an H-shaped structure thing that is formed by the fusion of four bones. The four bones are the frontal bone, parietal bone, the squamous part of temporal bone, and then the sphenoid bone. Okay, so this area is thin or thinner than usual. So any blow here, any damage here will cause an arterial injury here. And as you can see, the middle meningeal artery branches run below the therion. So any blow to the therion will cause the middle meningeal artery tear, and it will cause the extradural hematoma to appear here in the temporal area. So that is the most important one, as I said, in 85% of cases. Okay, so the presentation of the hematoma itself, we have what's called the textbook or classic presentation, which consists of three parts. The first one is the brief post-traumatic loss of consciousness. So the patient will have brief loss of consciousness. It is because of the trauma itself, because of the initial impact, as we say here. Then the patient will have what's called a lucid interval, where the patient will be fully conscious. The GCS will be 15. You will not see the patient suffering from anything, and this may be for several hours. Okay, then we have a phase what's called obtundation phase. The obtundation phase means the deterioration of the patient. So as the hematoma itself accumulates, the patient will start to deteriorate. So you may see loss of consciousness, or GCS will drop. You may see contralateral hemiparesis as the hematoma itself is pushing or compressing the brain. You may see ipsilateral pupillary dilatation. And this is, as I said, the effect of, or the mass effect of the hematoma itself. So the classic presentation is consisting of three parts. First part is a brief or acute loss of consciousness. Then the patient will have the lucid interval. He will be fully conscious. Then the obtundation or the deterioration phase after the hematoma itself accumulates. Okay, so as for the evaluation, first you will you will take a history from the patient. Then you will perform an examination. You will focus on the GCS of the patient, the pupils, the neurological deficit of the patient. Then you will perform a CT scan to evaluate the patient. Okay, and you will find this picture or this image here. Here is a bone window of the scalp. Okay, the bone window may show a fracture line. It may not show it, but most of the times it shows a fracture line. And in the soft tissue window, you can see here the classic shape or the biconvex shape of the hematoma itself. Here you can see some subcutaneous hematoma, but this is not important. And the hematoma itself is still small, so it did not push the brain to the other side. You can see here the calcine gyri are well seen, so the hematoma itself is still small. Okay. In this picture, the hematoma will get bigger. Okay, I just put this picture here to focus on one thing, which is the shape of the hematoma itself. It will be a biconvex in shape, as it does not cross the suture lines. It cannot cross the suture lines, so it will accumulate to the inside, pushing the brain. Okay. And this white arrow here is showing the tentorium cerebelli, which is a fold of the dura. So the hematoma itself is extradural. It's above the dura, so it can push the dura to the inside. It can push the dura and the brain to the inside. So it can cross the dural folds. So that's a major differentiation thing between it and the subdural hematoma. And we will make another lecture on the subdural hematoma. But for now, let's say that the extradural hematoma can cross the dural folds. Okay, that's a major differentiation thing. There is another picture that you saw in the first of this lecture. Okay, that shows the extradural hematoma itself. As it accumulates, it became bigger in size. It pushed the brain to the other side. You can see here the what's called midline shift. The midline shift meaning the midline of the brain, the middle part of the brain, is being pushed to the other side. The calcine gyri are being effaced, meaning that they are not visible anymore. They are not visible anymore. If you compare it with the first picture, you can see the calcine gyri. If you compare it with this picture, you can see clearly the calcine gyri of the brain are still visible, because the hematoma itself is still not big enough to cause this. But in this picture, you can see the midline shift, the direct mass effect of the hematoma itself. And this will help you to make a decision to evacuate this hematoma urgently. Okay. Here you can see some subcutaneous or subgaleal hematoma. The jet black areas, the black areas are from air coming through the wound in the scalp. That's not really important, but that's a differentiation thing that we will tell you that the patient had a head trauma. Okay. So the features of the CT scan, we said all of them. Okay, so it should be it should be a biconvex or lenticular hyperdensity. Hyperdensity means that is more close to the bone. It's more white, meaning it is more hyperdense. Okay, and the second thing, it is adjacent to the inner table of the skull, so it's directly below the bone, because the injury to the bone that caused the arterial injury that caused the extradural hematoma. So it is above the dura and adjacent to the bone. And the third thing is it can cross the dural barriers, as we saw here in this picture. It crossed the tentorium cerebelli here, the white area, the tentorium cerebelli, but it cannot cross the sutures. That's what makes it biconvex in shape. Okay, and the last one, it is mostly uniform in density, because it is all acute blood, and acute blood will have the same density, the same color. Okay. To talk about the treatment of extradural hematoma, it is almost always surgical. So it is almost always to do a surgical evacuation, but there are some indications to this surgery. Okay, so what are the indications? If the extradural hematoma volume with more than 30 cubic centimeters, it should be evacuated regardless of the GCS. So if the patient is fully conscious, but he has extradural hematoma which is more than 30 cubic centimeters, this should be evacuated immediately. Okay, and these are other indications, okay, for the extradural hematoma to be evacuated, but they are in reverse. We are talking about if the patient can be managed non-surgically. So we will talk about if the patient can be managed surgically, due surgical evacuation. So as we said, if the volume was more than 30 cubic centimeters, if the thickness of the hematoma is measured from the biggest part of the hematoma, from the inner part of the skull to the most inner part of the hematoma itself. So if the thickness was more than 15 millimeters or 1.5 centimeter, and as you can see here, it's obviously that it is more 1.5 centimeters. Okay, And the third one, if the midline shift was more than 5 millimeters. Okay, so the hematoma itself will push the brain. As we said, the middle part of the brain will be pushed to the other side. As we can see here, the middle part of the brain, the shadow of it is pushed to the other side. So we will measure from the middle part of the brain to the pushed part. If it is more than 5 millimeters, then the hematoma is surgical because it is causing damage to the brain itself. Okay, and then if the GCS was below than 8, so if you had a hematoma which is less in volume than 30 cubic millimeters, but the GCS of the patient is deteriorating, or he is deteriorated when he came to the ER, so it is surgical for sure. And if the patient had a focal neurological deficit, meaning weakness, meaning some deficit, okay, he will be surgical. So there are the indications of surgery. As we said, you will need surgical evacuation if the hematoma itself was more than 30 cubic millimeters, or the midline shift was more than 5 millimeters, or the thickness of hematoma itself was more than 1.5 centimeters, or the GCS of the patient was less than 8. So the patient requires intubation from the beginning, then this is a serious case. This is a severe head trauma, okay? And if the patient had a focal neurological deficit, meaning that the brain itself is injured, so he may need surgery. He surely will need surgery, okay? So after talking about the hematoma itself, the evaluation and the management, we will take a small case. I will read the case, and you can read with me, okay? So we have an 18-year-old man who attended the emergency department 30 minutes after being hit on his head with a champagne bottle. So a direct blow to the head. A head trauma happened here, okay? There was no loss of consciousness, okay? But the patient had vomited several times, so he had vomiting. He complains of severe headache. He had a severe headache. And on his left side of the head, that's not really important, but maybe that's the part that he was hit on. On examination, his GCS was 15, pupils are equal and reactive, and there is no focal neurological deficit. So the patient has not had, did not have loss of consciousness. His GCS was 15, pupils are equal, no focal neurological deficit. From the data that are given here, you may say that he had a minimal head trauma, as we said about the classification of head trauma, and you are not wrong. This is right, but the patient had severe vomiting and he had severe headache. So these are signs of increased intracranial pressure. These are signs that are telling us that there is something going on in this patient, okay? We will talk about the increased intracranial pressure in another lecture, but now let's see those two signs that will lead you to be worried, to be concerned, to order a CT scan. So you order the CT scan and you can see this. This is the biconvex shape, the classic shape of the extradural hematoma, which is pushing the brain, pushing the midline, causing a midline shift. And you can see here some subgaleal hematoma or subcutaneous hematoma, as we said, okay? So you see a hematoma, okay? We have three questions in this case, okay? First of all, this is the comment that you are going to say on the axial CT head, that there is an extraaxial biconvex high density lesion overlying the right frontal lobe. It's a typical of extradural hematoma. There is a midline shift with distortion of the ventricles. There is a scalp hematoma on the right, as we said here, okay? So this is the comment on the CT scan itself, okay? And we have three questions. The first question is, explain why extradural hematoma typically appear biconvex. And we said that you can pause the video, you can answer all the three questions, and you can come back again and see if you are right. And the second question is, the rupture of which vessel usually leads to an extradural hematoma? And the third question is, what is the management of this case? Okay, so you can pause the video, you can answer them, and you can come back. Okay, so the first question is, explain why the extradural hematoma typically appears biconvex. As we saw here in this picture, I will go back to it. The hematoma itself appears biconvex because it is under the bone, it is pushing the brain, it can cross the dural folds, but it cannot cross the sutures. So it appears biconvex. The second question is, what is the most injured structure it will be the middle meningeal artery, which is a branch of the maxillary artery, which is a branch of the external carotid artery. And the management of this case, you can go back to the indications of the surgery, sorry, but I see that there is a midline shift. I see that the thickness of the hematoma itself is more than 1.5 centimeters. So I see that this patient is surgical, and he will need a surgical evacuation. Okay, so that's been it. Thanks for watching. If you have any question, just let me know in the comments. The next lectures will be about the subdural hematoma, the increased intracranial pressure. But yes, that's been it. Thanks for watching.